So as I said, this is a left revision stapedotomy. This patient was operated 2 times before, and following both the primary and the revision surgery, there was no improvement. So it was immediate failure both times. And I did the tympanomeatal flap elevation, and what we have is this Causse Teflon piston, which is attached to the incus. You can see that if I move the malleus, you see the malleus incus are moving well, and the shaft is there, and you can see we have a posterior, a shaft which is definitely really posterior, probably moved posteriorly, and there is no movement in the round window, because we have to make a decision whether or not we're going to change it and remove this prosthesis. So I'm trying to move this shaft, and you see there is no light movement in the round window. So it's clear that it's not working. So by identifying this, I can remove the prosthesis. So I'm going to use a chouk neuf chouk, 3 de chouk, and I will remove this prosthesis. So I need to grab the anterior part of the loop, holding the incus at the same time and trying to open up the loop like this, and now I can remove it. Okay? All right, good. Now I'm going to check again malleus incus. So malleus is intact, which is fine. So you see moving normally. And now I need to check the footplate. 3 de chouk, s'il vous plaît. So I have some fibrous tissue and some vein maybe, which is there. So I'd like to remove that, because I need to check the footplate, and I don't really see any opening. There is maybe a fracture of the footplate. We'll see that in a second. Vous pouvez me mettre une fraise neuve, s'il vous plaît. Un 7, s'il vous plaît. Anyway, all in my experience, usually the immediate failure is usually related to prosthesis problem. Short prosthesis, intact footplate sometimes, and it's about the same thing. I think probably there was a fracture of the footplate, and the previous surgeon decided not to perform fenestration. You see the fracture here in the middle? So I think it's the cause. So there is no fenestration, okay? So what I'm going to do now, I'm going to check the mobility of this posterior part of a footplate to see if I can perform a safe stapedotomy, and this is fixed. Okay, so we're going to use that. But first I need to measure. So I will now measure the distance from incus to footplate using a regular Stapes measuring rod. So I'm going to touch the posterior part of a footplate, and you see that we are in front of the second notch, which means 4 millimeter. 4 millimeter. Okay, so now we need to perform a fenestration. We need to fenestrate the footplate. Alors mettez la tête en déclive encore un peu, s'il vous plaît. Avec un 7 maintenant. Hein. Stop. Donnez-moi d'abord un 9 en le changeant, s'il vous plaît. Il y a du sang un petit peu, donc je vais le cleaner, là, tout ça. Non, ça marche pas, l'aspi. Marche pas, hein. Ben oui, c'est pour ça que je voulais changer. Non, là ça marche. Okay, you can see a bit of a residual posterior cruise here. Plat rond, s'il vous plaît. Alright, I try to increase the view of the footplate. And of course, what I want to do is to perform a fenestration of a posterior part of a footplate, stapedotomy, posterior stapedotomy mainly. Okay, so we're going to use 0.7 millimeter diamond dust burr and set, s'il vous plaît. And with my left hand, I'm going to use 0.7 millimeter diameter sucker. And I need to take care of the fact that there is a partially fractured footplate. So I need to go there and start drilling. And you see, I'm always starting drilling before touching the footplate and just leaving the diamond dust doing the job by itself without any pressure, like this, step by step. And I do it very, very gently because of this fracture. I don't want to dislocate the posterior part of a footplate, of course. You can see I'm drilling progressively the footplate without any pressure. It's starting progressively to get in. Right, more and more. So it's pretty refixed, probably following the fracture. So now it's definitely fixed. So you see, this is definitely the cause of failure. It's because there was no fenestration. Okay, there we go. We have the perineal flute coming up. And I need to check now how it goes. And now we have a nice fenestration. You see that? I'm going to enlarge it a little bit. And I think I'm going to measure again, because I'm not sure about the length now. Okay, there we go. And I will measure again now. Mesureur. There is some residual membranes which I'm not going to remove. We don't need that, okay? And now you see it's more close to 4.5. So it was pretty thick. Okay, so I'm going to cover it now with the vein. Plein rond encore, s'il vous plaît. 4,50 donc. Okay, good. Alright, so of course the vein will be too big, so I'm gonna remove that and even press it, because for the case I think it's a little bit too thick. J'ai besoin de la presse, s'il vous plaît. I like to have really thin vein. It's not the same thing with a torp, but with the piston I think it's better to have a thin vein. There we go, I'm going to press it now. I put it on the press. And now you can see it's much nicer than before. That's going to be really nice. And I'm going to use only a small part of this. I will remove all this part on the right. There we go. And this will be used. So I'm going to grab it with a 0.9 millimeter diameter sucker, sticking the vein to the shaft of the sucker. Not the shaft, but the sucker itself. And I'm going to introduce the vein with the sucker and stretch it with my right hand with the needle. And which is good is that this type of suction system helps you very much, because then you have a real instrument with the sucker. There we go. So you see I'm holding the vein with a suction tube, and now I can stretch it with the needle in order to cover completely the footplate. And now, thanks to the translucence of the vein, we know exactly where the fenestra is there. So I'm going to cut now the prosthesis. 4,50. Alright, so I'm using now a cutting block. And of course I will put the piston, which is a 0.4 millimeter diameter Causse Teflon piston. And I'm going to cut it at 4.5. So I'm going to use this hole, 4.5, and holding the loop while I'm cutting the shaft through the instrument, the cutting block. And now what I need to do is to break the memory of the loop. So I will hold the shaft like this with my left hand and just break the memory like this. 0.4. Yeah, because of the vein. We do 0.8 millimeter fenestra, and because of the vein, we need to use 0.8. Sorry, we need to use 0.4 millimeter shaft. Okay? Without vein, use 0.6. With vein, you use 0.4. All right. So I'm going to introduce now the shaft first within the fenestra, which is not yet the case. Because you remember that the fenestra was a little bit posterior. So let me see, it's not working well at the moment, so I need to grab it differently. I grab it and now it's fine. And now I can just introduce the shaft within, around the incus, the loop around the incus. And now I'm going to close the loop with the two hooks. You can use curve forceps, anything, but we need to close the loop, helping the memory of the Teflon. Like this. Okay, now it's fine, and I need to look for the bending sign just to be sure that the prosthesis is in good position and good condition. The piston should bend but not move, like this. And it's fine. And it's clear that in this type of situation we really should have a good result, because in fact we had an intact footplate, meaning that the previous technique was not complete. Difficult to see any round window sign, by the way, in this case. Oh, difficult to see that, but anyway, it's clear that there is something different now. We couldn't see it because the footplate was fixed, and now the membrane is deep, I think. Yeah, I can see it moving, so it's fine. A little bit of the blood here. Okay, good. So now I'm going to reposition the and see about the malleus. We can check with the malleus, and you see the movement with the malleus, which is fine. And now we're going to reposition the tympanometer. Ah, there is a small perforation here, a small tear. So I'm going to use a residual vein graft. Donnez-moi la veine, s'il vous plaît. It's a vein? Yes, because it always has some residual vein, and by putting it underneath the tympanic membrane it helps. Because in fact, probably we don't need to do it because it's just a small perforation. But I always prefer to close any tear that you make, and the vein is good for that. Not for a real tympanoplasty, of course, it's too small. But this, you see, it's nice. And that's enough. Okay, good. I'm going to place now the MRSA. Yeah, the sticky side up, opposite to the for the footplate. Allez-y. Okay, fine. I think good case. Very interesting.